Mr. Boyle.
Mr. Chairman, through the Chair, I would like to thank the members of the committee for coming along to listen to this, what I think is an important issue this afternoon. I would like to stress that all my travel expenses and hotel expenses, living expenses coming to this were paid for by myself on my way to a meeting in New York. So I'm not speaking on behalf of any individual organisation or company. I'm speaking on behalf of the global public health community. I'm a member of the National Academy of Scotland, the National Academy of Science of Hungary and the European Academy. I've got what some people would say an extensive publication record in public health, and I was recently, for 5 years at the mandate, I was the Director of the International Agency for Research on Cancer, which is the World Health Organization Cancer Unit, and that was based in Lyon. I'm here today to talk about this issue. It started off with me in the late 1980s when I was involved in a very large international study involving several tens of thousands of people who had cancer and were given chemotherapy, and we established that there was quite a significant excess risk of second primary cancers in patients getting specific types of chemotherapy. In addition, we also discovered that there was problems with nurses in terms of excesses of bladder cancer associated with certain types of chemotherapy, and also they suffered more premature births, more malformations, and more problems with their pregnancy. So it was a very important point that came out of that was that there was a change in how the regulation for preparing chemotherapy in hospitals. Those specific extractor fans and hooded compartments established that the only place in hospital where you could prepare those chemotherapy to prevent the exposure to the nurses, to the medical staff and to other auxiliary staff in the hospitals. Of course, there are specific rules in hospital for the disposal of waste, those people getting radioactive tracers, for example, and the patients receiving chemotherapy. There are specific norms for the disposable and the capture and disposal of waste like that in hospitals, but nothing in communities. A lot of people now, and there's an increasing tendency, there's more and more people around the world with cancer, particularly in the high-resource countries, because of the growth and ageing of the world's population. There is an increased move for people to get chemotherapy in hospital as outpatients and then to have to go home. And we've established that in patients who receive chemotherapy, for the 2 or 3 days following that chemotherapy, there are 27 different types of chemotherapy which lead to the excretion in either sweat, vomit, urine or faeces, 27 identified human carcinogens which are excreted in that format. Patients, when they go home, depends on countries. Some doctors tell the patients to, if you've got 2 toilets, just use one for yourself. If you use a toilet, flush twice. But that doesn't get rid of the problem, because the problem is that these chemotherapeutic agents, these human carcinogens, are going to end up somehow in the water and the sewerage supply. And that is really quite an important issue. The principle involved here, the basic principle is to recognise this as a public health issue which requires steps to be taken to do something about it. This is a key important issue. I think that the time has come. I blame myself to a large extent, because it was only a year ago that I thought, this is important. This is something that we haven't taken care of. In science and medicine, we've taken enormous steps to identify chemicals, identify lifestyle factors which are important causes of cancer, and yet we've taken steps to do everything we can to prevent the exposure of the population to this. And this is an area where it has slipped through the net, and one in which I think that the scientific medical oncology community, of which I'm a member, I'm here to say mea culpa. This is something that we forgot about, took our eye off the ball, and I think it needs urgent attention. I think there are 2 major issues. The principle is that this must be recognised as an important threat to the health of carers, family members and the general population who may be exposed to these carcinogens through the water or accumulation in sewerage or whatever exposure could be. We need to do more work on that. But the underlying principle is that we need to recognise that as an issue, and then the political issue is who do we get to actually pay for this to make sure that we can get rid of this, minimise this or eliminate totally this exposure to the general population. I really thank you for your attention. I hope that you can consider this bill, but I think the important thing is, first of all, get the underlying principle out there. We need leadership in this area to say that this is an important issue that we must take steps to avoid. Thank you very much for your attention, Mr. Chairman.
Are there any questions? I have one question. There has been some... The issue on this in past years that we've had similar legislation has always been who pays and how do we pay.
Yeah.
And that is more complicated post-Affordable Care Act, in that if it was mandated that it be paid by insurance from the revenue from insurance, that it could potentially be determined as a state liability. And so, based on previous testimony, we understand the issue very well, but we still have who's going to pay as a complexity. One of the things that has been discussed recently is the concept of producer involvement, as it has been taking place with lead paint, mattresses in Canada and other locations, electronics, and there are several examples now of those systems working very well. So has that been explored as part of a solution for financing this type of...
I must confess I'm not an expert on the legislation in different states in the United States, but there's others with me and this here today who maybe elucidate on that. One of the things which drives me on is this: one of the great things for environment and public health, this is an environment and a public health issue, was the work of Ralph Nader in the 1970s, where he was mandated to lead, the government mandated him to have a reduction in motor car exhausts. So he got the big manufacturers together and they said, we can't do it. No, we can't do it. He said, okay, fine, you can't do it, but you'll get 2 years to half your emissions. So they all come back in 2 years' time and said, yeah, this is wonderful, we've done it, right? And they said, great, you've got another 2 years to half it again. And so there was a political will to have this, but the responsibility for doing it was left to the manufacturer and the cause of the pollution. And I think that's a good analogy for going forward here. Since then, we've got every car I know has got a catalytic converter, and that's one of the great things that come out of the industry work to produce that. So I think we need to look for imaginative solutions to solve this problem, but the important thing is to declare that this is a problem.
Thank you. Any other questions? Thank you.
Thank you very much for your attention.
Dr. Theresa O'Keefe.
I know you have a lot of testimony this evening, so I'm going to be very brief, and I'll try not to duplicate what Dr. Boyle said. In the U.S., there are over 200 drugs that are used for cancer treatment. Unfortunately, there are some of them that actually cause cancer, birth defects, miscarriages, immunological damage to healthy people when they're accidentally exposed. And this is where we have a big concern. We have known since the 80s that nurses who are accidentally exposed have severe effects, as Dr. Boyle had mentioned. They develop cancer. They develop breast cancer. They develop colorectal cancer. They develop, there's evidence coming out on bone cancers. And so we have spent a lot of time in the medical industry working on how to protect them from the excreted. It's not just before the drugs are given, it is after the drugs are given, because the patient's body, there's 27 of them that the patient's body cannot metabolize and excrete it. And as we heard, it comes out in the urine, the feces, the vomit, the sweat, and saliva. And it comes out in the 1 to 2 days, usually after every infusion. If we can control those excretions for that period of time, we can actually protect people. It used to be that we assumed, the patients were confined to the hospitals and it was managed. But now we are sending it home. It is better for the patients to go home right away. It is less expensive for them to go home right away, but we are not having the protective equipment or the protective procedures follow the patients home. And unfortunately, we are seeing data that's coming out where not only are the cancer patients excreting these drugs, but we're finding that the spouses of the cancer patients are actually excreting drugs at higher levels than is found in the urine of the nurses back when we were not minding the situation. And from the 30 years of human studies, we know that healthy people exposed for these drugs will get cancer, birth defects, miscarriages, and all types of issues. And there is this question, and the other thing is, not only is it right in the house that you have the exposure, is these 27 drugs cannot be cleaned out by wastewater treatment or drinking water purification technology, any technology that we have today. For example, greater than 98% of cyclophosphamide and isophosphamide, which are two cornerstones of breast cancer treatment, pass through all wastewater treatment and drinking water purification that we have. If it is flushed down the toilet, it is going to end up in our groundwater, and this is a real problem if you're on a septic system and have a well, because it is going to be there. And we know from scientific data that it exists in the soil for years. So we've got to maintain it. Now, yes, there is a real serious question about cost. Well, I can't address, there is a lot of work. There's been suggestions about these various stewardship programs, and that is a possibility. But I can tell you very clearly what happens, this expenses, when we don't control it. Cancer treatment for every patient, every family giver who is exposed and gets cancer, on average is $185,000 for treatment. But there are two cancers that my background is drug development, and I will tell you that the best way to treat cancer is to prevent it. But there are two cancers and pediatric cancers that the #1 cause is exposure to chemotherapy. That's acute myeloid leukemia and acute lymphocytic leukemia. Those children, when they get it, it is 2 to 3 years of extreme chemotherapy. And then in 1/4 of the pediatric patients with ALL, and it's 1/3 of those with AML must have a bone marrow transplant. Bone marrow transplants cost $800,000 as a minimum if there is no complications. If there are complications, you're talking $2 to $3 million. Even with all that treatment, 1/10 of the children with ALL will die. And it is almost 30% of those with AML will die. And these children have gotten it from exposure to chemotherapy. That is what we are trying to prevent. It is a very low cost relative, because it's only a short time that we must manage the waste. But if you don't manage the waste and you develop cancer, especially a young cancer, it is incredibly expensive to treat. And right now I think it's something like 80 to 85% of patients are treated as an outpatient. It is better for the patient. No two ways around it. You do not want a sick patient in a hospital. It's also psychologically better for them to go home. But a lot of their care actually falls onto their caregivers. Family members are so critical to a cancer patient's treatment. Absolutely. Anybody who's ever supported a family member going through chemo knows what we must do for them. These are the people that this bill is trying to protect. We are trying to give the cancer patients the best care, but we don't want them to feel that by taking care of their family member or having their family member take care of them, that they are putting their family member at risk.
I will let you know that we've heard this bill in years past, and the concern about how dangerous the discharge from those who are cancer patients to others has been well testified. And I think the remaining issue is, how do we pay if we choose to dispose of them more safely? So
that is, it is one of these things, is that we are working on that. We are working on a stewardship program. We are working on communicating with the federal government,
Yep.
with CMS, trying to come up with ways. It is a very important issue, and we understand that Rhode Island, I've heard this, it is, you must come up with a way to cover the costs, and we are working on that. But it comes about is that if there is no push from legislators to bring this issue forward, we will not get anybody else to step forward. Unfortunately, it falls down to you, the legislators, to lead the way frequently. These issues have been known about for a long time, but they haven't been communicated very well because
This committee, they've been communicated very well, and this is not the first year they've been communicated very well. And we understand the issue enough that we do want to find a solution.
Yes.
But the solution isn't financing, as often what it comes to on a
Absolutely.
state and federal complexity. And bringing in the manufacturer liability as a model gives us another opportunity that I think we're still looking at.
I would be delighted to hear that. I am a drug developer.
Yeah.
I am not a legislator. This is why I'm coming to legislators for help. Any questions?
Thank you.
Thank you.
Just we have a very busy